This is a not-for-profit instructional video intended for ICU and sleep medicine at Henry Ford Hospital. Created by Dr. Jovica Veljanovski, Senior Staff Attending in Sleep Medicine, as well as the Medical Director at the Cottage Sleep Center. Regarding the Henry Ford Non-Invasive Positive Pressure Ventilation ICU Titration Protocol for Chronic Hypercapnic Respiratory Failure. Created by myself, Dr. Jovica Veljanovski, as well as Dr. Louisa Bazan, the Division Head and Program Director for Sleep Medicine. Reviewing some of the basic forms of PAP therapy in the ICU, you have CPAP as well as BiPAP. Beginning with CPAP, it stands for continuous positive airway pressure, and as you can see in the diagram, has one continuous pressure throughout inhalation as well as exhalation. On the other hand, you have BiPAP, which stands for bi-level positive airway pressure. It has two different pressures, an EPAP and an IPAP. The EPAP is generally the lower of the two and occurs during exhalation, while the IPAP is the higher of the two and occurs during inhalation. The difference, or delta, is known as your pressure support. Generally speaking, your EPAP helps keep your upper airway compartment open, preventing upper airway collapse that we see in obstructive sleep apnea, while increasing your IPAP and hence your pressure support will help with ventilation. The location of the protocol can be found at hfhpalm.com. Both your fellow and attending can help you if you have difficulty locating this. Once there, under categories on the left-hand side, I ask that you click on MICU. Then scroll down until you see NIPPV protocols in the ICU. There are 5 separate files that you should pay attention to. The first one is the instructional video for Hypercapnic ICU Titration Protocol. That's this video that you're watching currently. The next is the Concise Hypercapnic ICU Titration Protocol, which we'll be going over throughout this video. The next is the Detailed Hypercapnic ICU Titration Protocol, which we will not be going over through this video, but if you want more depth in the protocol, you can go and reference that. In addition, there's a file that looks at devices and masks available, which we will go over during this video. And the last is the Discharge follow-up template, which we'll also go over during this video. By clicking on the Devices and Masks Available file, you have information on the different ventilators as well as masks that are available in the ICU. Starting with the V60 ventilator, patients typically come up from the emergency department on the V60. It can provide different modes of PAP therapy, including CPAP, AutoPAP, BiPAP, as well as first-generation AVAPs. In addition, the highest IPAP that can be achieved by the V60 is 40 centimeters of H2O, which is different than the Loomis, which I will get into shortly. It can only be used in the ICU, not on the GPU, and it does not record continuous information such as the Loomis device. The Loomis device is what you picture a BiPAP machine to look like. It's a sophisticated device that has all PAP modes, including CPAP, AutoPAP, BiPAP, BiPAP ST, Auto BiPAP, AVAPs, and ASV. Different than the V60, the highest IPAP that's attained is 25 centimeters of water, and again, the V60 was 40 centimeters of water. It, on the other hand, does capture continuous data that can be downloaded the following day, and it can be used both in the ICU as well as the GPUs. In addition, these are the 4 different masks that are currently available inpatient for patients that do receive positive airway pressure. Keep in mind, if patients are having comfort issues after a few days and you've trialed a few of these masks, you could always reach out to Sleep Medicine, and we do have access to additional masks at our sleep center at the Ford Pavilion. The protocol is a respiratory therapist-driven protocol, only in the ICU and not the GPUs. It focuses on the following 4 pathologies: COPD, restrictive lung disease due to neuromuscular disease such as ALS, restrictive lung disease due to chest wall deformity such as kyphoscoliosis, OSA plus OHS, and typically another pathology for the patient to get admitted. In addition, overlap syndrome, which is a combination of OSA plus one of these other diseases. And if you do get a tracheostomy patient, those patients are managed directly by Dr. Bazan. Now, discussing the appropriate sleep consults and the inappropriate sleep consults. The appropriate sleep consults are for patients that are hypercapnic due to OSA-OHS or overlap syndrome, with OSA being the main reason that they're hypercapnic. While patients that are hypercapnic because of COPD or either of the restrictive lung disease categories, those are to be managed by the ICU and not sleep. Keep in mind, sleep is more than happy to provide direction if necessary. There are smart phrases for both orders and assessment and plans for all of these pathologies. They are Henry Ford wide available smart phrases, and we'll go over them throughout this lecture video. Going back to the hfhpalm.com website and looking at the concise hypercapnic ICU titration protocol and selecting it, you get the protocol. At the top, you can see manual titration as well as auto titration, which dictate the type of order that you place. Moving from left to right, we have restrictive lung disease due to neuromuscular disease, restrictive lung disease due to chest wall deformity, COPD, and then OSA-OHS. We'll begin with restrictive lung disease due to neuromuscular disease, such as in ALS. Anytime a patient with ALS presents to the hospital and is found to be hypercapnic, this is considered an emergency and they cannot leave the hospital without a BiPAP ST machine. They need one of the 4 criteria in order to qualify for that BiPAP ST prior to discharge. If they are hypercapnic, having an ABG greater than or equal to 45 is enough. However, if for some reason you don't have an ABG, having an FVC of less than 50% of predicted or a MIP of less than -60 is enough, either or. Or the last criteria showing that the patients are hypoxic for at least 5 minutes while you've had a recording time of at least 2 hours of time while on the patient's prescribed FiO2. If you have any of those 4 criteria, they will qualify for BiPAP ST. In addition, there needs to be appropriate documentation of the problem, and we've created Henry Ford wide smart phrases, as you can see, bolded in red, that are to be placed in your assessment and plan. In addition, the order that you use in these instances should be ventilator, adult, non-invasive, and the resident places that order along with the order instructions in the comments section, and there's another smart phrase bolded in red, which we'll go into more detail on the next slide. This is what the order looks like: ventilator, adult, non-invasive mode. Typically routine. You can select continuous at bedtime as needed, or at bedtime. We would likely select bedtime. You don't really have to place anything for or starting. The mode is BiPAP, and in this instance, at the beginning, you'll place 13/5, and then adjacent to it, notice that I placed C comments below for both of them. And in the comments section is actually where we're going to place the protocol itself using the order smart phrase .NIV order rest NM. This is the direction that the respiratory therapist will have for the protocol. As you can see, place an arterial line if possible. Please discuss with your staff and your fellow. Get an ABG at the beginning of the titration as well as in the morning, or the highest pressure tolerated. We want to see if the protocol is working, so having a base at the beginning of the protocol, typically at night, and then in the morning, we'll see how well the protocol actually worked. In this case, it's a manual titration, and so we start with an EPAP of 5 and a pressure support of 8. When you add the pressure support of 8 to 5, you get 13, and that's why you have an inspiratory pressure of 13 on the left and an expiratory pressure of 5 to begin with. So this is a manual titration, and the respiratory therapist will increase the pressure until the patient can no longer tolerate it. The pressure support only goes up by 15 or up to 15. If the PCO2 drops to below 50, you can stop the titration. In patients with neuromuscular disease, you always use a backup rate, and you can select either 10 to 12. The usual goal for neuromuscular patients is an IPAP of 20, so it would be 20/5. You only add oxygen to keep the saturation greater than 90%. Always call the head RT after placing this order. Call 160627 and they will dispatch it to the appropriate RT. Next is restrictive lung disease due to chest wall deformity. The patient needs to qualify for BiPAP for discharge, and there's two criteria. The first is being hypercapnic with a PaCO2 of at least 45 millimeters of mercury on a blood gas drawn during that admission, or being hypoxic less than 89% for at least 5 minutes with a minimum of 2 hours of recording time on the patient's prescribed FiO2. In addition, the appropriate documentation in order to get BiPAP is necessary, using the smart phrase .NIV AP REST CW. The resident also has to place the appropriate order, which is ventilator adult non-invasive, and then in the comment section places .NIV order REST CW. This is the ventilator adult non-invasive order that you'll see, similar to the restrictive lung disease due to neuromuscular disease. You'll begin with 13/5 and place comments in the comment section, and notice beside the 13 and 5 it says see comments below. In that comment section you'll place .NIV order REST CW, and once again this is the protocol that helps guide respiratory therapists. Residents should place an arterial line if possible, if okayed by either the fellow or senior staff. Get an ABG at the beginning of the titration and in the morning, or the highest pressure tolerated. We start the manual titration with an EPAP of 5 and a pressure support of 8. You add the 2 and you get 13, and that's how on the left hand side here you get an inspiratory pressure of 13 and an expiratory pressure of 5. We keep the EPAP at 5 and we increase the pressure support up to 20 with an IPAP of 25 if the patient can tolerate it. In addition, if the PaCO2 drops to less than 50, we stop the titration. Keep in mind, if the PaCO2 worsens despite maximum BiPAP tolerated and it actually increases by 7 points, that's an indication to add a timed element, and we can have a backup rate of anywhere between 12 to 15. But typically we begin at 12 and increase as needed. The usual goal for chest wall deformity patients is an IPAP of 25, and we only add oxygen to keep the saturation above 90%. As always, call the head respiratory therapist after placing the order and they will appropriately dispatch the order. Call the number 160627. Next, we'll discuss COPD. In order to get BiPAP for discharge, the patient does have to have an ABG revealing hypercapnia with a PaCO2 of at least 52 millimeters of mercury. In addition, the patient does have to have documentation using the smart phrase .NIV AP COPD, and it must be noted that the patient is obstructed using Gold's classical FEV1 to FVC ratio of less than 70%, either in the patient's record or bedside spirometry needs to be completed prior to discharge. Respiratory therapy has agreed to do bedside spirometry when the patient is considered clinically stable, and the order cannot be a stat order. The resident places the order instructions within the comment section using the smart phrase .NIV order COPD within the order ventilator adult non-invasive. COPD patients must complete a nocturnal oximetry post-titration when considered clinically stable. Oftentimes this is performed on F2. The nocturnal oximetry needs to be completed on a minimum of 2 liters of oxygen or the prescribed FiO2, whichever is higher. And it needs to demonstrate an oxygen saturation of less than 88% for a cumulative total of at least 5 minutes. And the nocturnal oximetry has to be at least 2 hours long in order for the patient to qualify for BiPAP. The non-invasive ventilation order that's placed is ventilator adult non-invasive mode, selecting BiPAP. You begin with an inspiratory pressure of 13 and an expiratory pressure of 5. Then place see comments below. So in the comments section, the smart phrase .NIV order COPD is placed. This provides direction to the respiratory therapist. If possible, place an arterial line. Discuss with your fellow and or attending. Get an ABG at the beginning of the titration as well as in the morning or the highest pressure tolerated. As mentioned on the side, you begin the titration with an EPAP of 5 and then you add a pressure support of 8. So that's where you get 13 over 5. We keep the EPAP steady and increase the pressure support up to 20 for an IPAP of 25 if the patient can tolerate it. If at any time the PaCO2 drops to less than 50, you can stop the titration. If the PaCO2 worsens despite maximum BiPAP tolerated, and it actually increases by 7 points, that's an indication for BiPAP ST, and you can introduce a backup rate of 12, and if necessary, increase it to as high as 15. The usual goal in COPD patients is an IPAP of 25, and we only add oxygen to keep the oxygen saturation of at least 90% or around 90%. As always, call the head respiratory therapist at 160627. Next is OSA/OHS. Notice the auto titration order is different than the manual titration order. In addition, this is the appropriate time to consult sleep medicine. The auto titration order uses auto modes. Examples are auto PAP, which is otherwise known as auto CPAP, auto BiPAP, and second generation AVAPs, which is beyond the scope of this discussion. Auto modes in general set a minimum pressure and a maximum pressure. When you have auto BiPAP, you have a set pressure support that does not change throughout the titration. Keep in mind there are contraindications to using auto mode. When a patient is on greater than 6 liters of O2, it's contraindicated to use auto modes such as auto BiPAP and auto PAP. Heart failure with reduced EF is also a relative contraindication for auto modes. Also note, portable sleep testing can be done on no more than 2 liters of oxygen. So if a patient is on 3, 4, 5 liters, a portable sleep study should not be completed. In addition, portable sleep testing is to be completed when the patient is considered clinically stable, and it is only ordered by sleep medicine. Sleep medicine will call 160627 to let the RT know that the sleep study order has been placed. The actual order is an auto titration order, which is linked to a pulse oximetry nocturnal, which is performed by the RT. This is the auto titration order for auto CPAP. Notice that there is a high pressure of 20 and a low pressure of 5. So the patient begins at 5 and titrates up accordingly to overcome an upper airway obstruction. You'll place the .NIV order a CPAP in the comments section. This provides the direction to the respiratory therapist for the protocol. The resident will place an arterial line, but discuss with both your fellow and attending. Please get an ABG at the beginning of the titration as well as in the morning. And again, note that the minimum pressure is set at 5 and the maximum pressure is set at 20, and the goal oxygen saturation is 90%, so add oxygen to keep the saturation just above 90%. Call 160627, the head respiratory therapist, to let them know that you've placed the order. Now, in order to qualify for auto BiPAP, the patient has to have documented auto CPAP failure. And auto CPAP failure is considered with these 4 different criteria. First, if the patient cannot tolerate auto CPAP pressure. 2, if the patient is clinically worsening. 3, worsening CO2 or no improvement of CO2 despite auto CPAP therapy. And 4, worsening hypoxia. That would qualify the patient for auto BiPAP. The auto titration auto BiPAP order introduces a pressure support indicated here as delta P of 8. This pressure support of 8 stays consistent, does not change throughout the entire titration. In the comments section, you'll place .NIV order A BiPAP OHS. Once again, this provides the direction to the respiratory therapist. The resident will place an arterial line if deemed appropriate by the senior staff and/or fellow. You'll get an ABG at the beginning of the titration and in the morning. So we begin with an EPAP of 5, given that the pressure support remains constant throughout the titration, and it's 8, so essentially you're beginning at 13/5. So as it titrates up, the delta will remain the same, and if you actually get to the maximum, it'll be 25/17. Once again, we keep the oxygen at or slightly above 90%, and you can add supplemental oxygen slowly to do so. Call 160627, the head respiratory therapist. After completing the titration, you have to place a discharge order prior to discharge. In Epic, select Discharge, Med Reconciliation, input DME CPAP and select the order. In Duration of Need, place 99. In the comments section, place the smart phrase .NIV discharge order. This is what you'll get. Notice the 4 modes of PAP therapy: CPAP, auto CPAP, BiPAP, and BiPAP ST. Input the settings for the mode that you'll be discharging the patient on, and delete the other 3. In regards to pressure relief, I often use 3, but if you're unsure, you can delete that. For CPAP mask and supplies, place per patient preference. Now going back to the hfhpalm.com website and focusing on discharge, I cannot emphasize enough how important it is to set up discharge follow-up for these patients. Going to this website and selecting the discharge follow-up template will give you this file, which will provide direction for the inpatient follow-up appointment process. We ask that you email sleepaccess@hfhs.org, and that will go to Jamie Sexton, the sleep medicine office coordinator, and she'll set up follow-up. The template that you'll use is, in the subject line, place inpatient titration sleep follow-up, place the MRN, the name, the discharge date, the time frame, typically 2 weeks after discharge, select the location most convenient for the patient, and what the patient's oxygen requirements are for discharge. If you have any questions or concerns about the protocol, please don't hesitate to reach out to me, Dr. Veljanovski. You can also reach out to Dr. Bazan, the Division Head and Program Director. In addition, you can reach out to Dr. Udaman, as well as Dr. Jaffrey.